some of the things that have been presented to us in testimony. So point out what I've seen and can also point out what you have heard as well.
This is as introduced, Jim.
As introduced. Again, Jen Carvey from the Legislative Council. This is S64, an act relating to amendments in the scope of practice for optometrists. This bill would, section 1 would amend definitions in the chapter on optometry to add in first, administering in addition to prescribing appropriate, this would say therapeutic pharmaceutical agents, gets defined in here. And then so under existing law, there's a list of things that that an optometrist can do in the area of, I'll back all the way up. Certain practices, examining human eyes and visual system for diagnostic purposes, diagnosing and correcting anomalies, in vision and enhancement of visual performance with a list of authorized activities. And then this creates a new provision around an optometrist holding an advanced therapeutic procedures specialty, and it creates that specialty. And there's a list of advanced therapeutic procedures that can be performed. So this is, I think, a lot of what you have gotten.
And this is where all of the controversy begins. It's the expanded scope.
Right.
And what is non-recurrent chalasia. It's not pronounced that way. I think it sounds like an N. Chalasia. And excision by active non-recurrent lesions. So the questions that have been raised, optometrists in the training section of this bill, where they have had additional training, suggest that they and state that they are capable of performing all of these when they've had that training. And the Office of Professional Regulations has validated that through the Sunrise report that we got. Ophthalmologists, on the other hand, believe a couple of things. One, that what some of the procedures here that include specific surgery, invasive surgery, it should not be included. I'm just trying to summarize what I've heard. So no injections, no penetration of the eye or the external eye, no scalpel, no injections for that.
Laser procedures.
Yeah, and then we'll go from there. So so there's a difference of opinion around the procedures. That's a huge difference. And we saw a video in here that came from the ophthalmologist, and we've heard from various folks from the optometry world as well. Go ahead.
Okay, so that was in the definition, all in the definition of practice of optometry, because it was talking about the scope, so it's appropriate, but I'm just reorienting us. There is a definition of adverse event, definition of therapeutic pharmaceutical agent. What that does not include. Section 2 relates to the renewal and some addition of an optometry license and some additional continuing 5 hours of additional continuing education in advanced procedures for licensees holding an advanced therapeutic procedure specialty. Section 3 has some specific prohibited practices that an optometrist could not do, except as very specifically set out in that definition under the practice of optometry. So not performing any ophthalmic surgeries with or without the use of lasers or injection procedures, except those that were affirmatively listed in the definition section. And then there's a whole list of procedures that an optometrist is prohibited from performing.
I have a question about that. You know, looking at why is that in there? Why would you need to list prohibited procedures if you're identifying acceptable procedures?
I think it's, I can't give you a specific answer. Great. Go ahead.
Heather Scholes from the Vermont Optometric Association. That was put in there because, as many of you know, we've been working on this bill for 5 or 6 years. And we wanted it to be very clear to the ophthalmologists and Vermonters what we were and were not doing. And that was actually a recommendation by OPR. OPR drafted this bill based on their report.
Okay, that's all. So we have to ask OPR. Right. And just offering clarity. This committee has not been working on this for 5 or 6 years and just got.
Okay, so that's the list. Lots of different surgeries and other activities. Also prohibits, affirmatively prohibits an optometrist from prescribing or administering a drug or other substance listed on Schedule 1. Nobody's allowed to prescribe those for the most part, or Schedule 2 controlled substance, except as set forth in subdivision 2, and that allows an optometrist to prescribe or administer hydrocodone in combination with analgesics for not more than 72-hour supply and no refills. All right, so then we have the subchapter 5, which creates the advanced therapeutics procedures specialty, authorizing a licensed optometrist to apply for an advanced therapeutic procedure specialty, authorizing them to perform advanced therapeutic procedures that are on that approved list in the definition section. As far as who is qualified, an optometrist has to get the specialty in order to perform the advanced procedures, and the Board of Optometry can grant a specialty to an applicant who is licensed in Vermont as an optometrist, meets applicable requirements for education and demonstrated competency that are in this section, and have completed the examination requirements in this section. Educational requirements, that if you may recall, there's sort of a split based on time of training. So an optometrist who graduated from optometric school or college prior to 2019 must do a postgraduate course sponsored by a board-approved organization with a minimum duration of 32 hours and specific didactic classroom instruction. Specifically go through unless you want to, and then an optometrist who graduated in 2019 or later does not have to do that. And I believe that testimony you heard was that has been incorporated into the training in more recent years. Preceptorship requirements, an optometrist has to do a preceptorship where they gain at least 8 hours clinical training supervised by a preceptor and demonstrate clinical proficiency with hands-on experience performing certain procedures on live human patients. There's at least 2 required each of these. And the preceptor has to be either an optometrist with a substantially similar scope of practice who's been licensed in Vermont or another U.S. jurisdiction to provide the advanced procedures for at least 3 years, or an ophthalmologist. There's direct and in-person supervision of the optometrist by the preceptor must take place in a state where the preceptor is licensed and authorized to perform the advanced procedures, and the preceptor has to certify that the optometrist has competently completed the required procedures and provide a log to the board. There's an examination requirement. The applicant has to successfully pass written and clinical examinations administered by the National Board of Examiners of Optometry, including ones on injection skills and laser and surgical procedures, and any other examination required by the board by rule. Provisions allowing advanced therapeutic procedures specialty by endorsement for someone who's already been licensed and doing this and is in good standing in another state. If that state has this expanded scope of practice that's substantially similar to the one in this bill and has been in good standing in this expanded scope of practice in the other jurisdiction for at least 3 years, and allowing an optometrist who received the specialty by endorsement to serve as a preceptor. Reporting requirements would require an optometrist to report any adverse event. That's why there was the definition of adverse event related to an advanced procedure within 30 days following the event.
So the report goes to
The board.
that's the way we're out. Okay.
It's my assumption that this is a report to the board, but it does not.
It doesn't say that. We should say something about it.
redesignating, just moving some sections around, and then, the active take effect on January 1st.
And I guess it's a question for OPR, and I'm not sure who asked it.
Oh, and OPR, I know that OPR wanted actually a year later. They wanted a year and a half. They wanted July 1st, 2028. I wrote in my draft.
Yeah, so that's a different date, but that's okay. Okay, so then the questions the things that came up while we heard testimony were, the extent to which the procedures allow for expanded scope, and we heard from ophthalmologists about the extent of that. There was a suggestion that I mentioned before on no injections and no scalpel. That one in particular who I know, I keep teasing him about it, about how, we need more eye care in Northeast Kingdom. So guess who that is? And then you look at the maps that the optometrists have provided us where there are aging ophthalmologists. And then we looked at the maps where there are 0 optometrists or ophthalmologists in Essex County and in Grand Isle County. So there is that kind of that rural healthcare need that could be there. But it doesn't extend directly to all of these procedures, because when we asked for data on the number of these procedures in the state, we came up with 11 selective laser trabeculoplasty, and I'm looking at Berlin, the data that we asked for, and 33 posterior eye capsulotomies in the state. And I guess if you have, who's doing them, one of the things we heard that is that repetition is important for these, pointing out all the concerns that I've heard, and I know some of these are not concerns to some people. But those are the things that I heard. So I heard geographic distribution and access to optometrists, as well as aging ophthalmologists. I heard the disagreement about scope and how it might be limited. And then I heard about the number of these advanced procedures that a well-trained optometrist might do, and currently that ophthalmologists are doing. So, I don't know what else I heard. I've heard some pretty negative and uncomfortable and not nice, use other words, emails. I won't state who they were from, but I found it really inappropriate. This isn't a personal issue. This is a professional issue, and we're trying to make a decision for professions here. If I had my way, based on some of the emails that I've seen, the bill would stay right there. I want people to know that, and people who represent this bill, you need to know that. Don't ever do this again. Thank you. I've had my say. So, committee, let's move on to the bill, and we're here. We have the bill as it was introduced and the information. You guys, I guess, you've been privy to the information as much as I have. Heather, you wanted to say something?
Yeah, thank you. Heather Schuldeis with the Metric Association. I just want to make sure that the record is clear. And as I said earlier, we've been working on this for 6 years. From the very beginning, ophthalmology has said no. And then in the 2023 report that OPR was doing, once ophthalmology realized the report was coming out favorable, they walked away from the report. OPR called us and said, we're writing this report. We don't have anybody on the other side. And we said, okay, they pushed themselves away from the table. That has happened every year since. And so for us, and Dr. McNally testified, that there is no negotiating. So we're not going to negotiate with ourselves when the education and training shows that they can do these procedures.
Understood.
It just doesn't.
I got it. We got it. Thank you. So is there anyone who would like to speak from the? Not my funnest day. I think Venus and what is the Mars or what? Okay.
See what's just in the notes.
Okay, committee, I've started the conversation. I want to know what your thoughts are here on the bill. And does anyone want to offer a comment? I mean, there are a lot of areas here to consider. The one thing I did mention, I should have brought up, and that is we never have this conversation when we're doing this kind of work, but malpractice insurance, professional coverage, and I don't know what this will do for optometrists if there's an expansion of scope to
For your insurance companies will adjust.
yeah, so we haven't talked about liability insurance here recently about this, but
Speak to that if you'd
Dean,
like.
you want-
Dean Barstow, Vermont Optometric Association. So remember that 14 states already offer this, and insurance companies that cover liability don't just cover one state. So it's a well-established track to make sure that those changes are covered by liability insurance. And actually, most of our policies already cover it, despite the fact that we can't do it.
Okay. Can you give me a ballpark figure for what the liability, because I know something about some liability insurance.
Like the cost of it?
Yeah, you know. It's a lot.
No.
I know it's a
Yeah,
lot.
I have other people who pay my.
Oh, you
bills.
can, sometimes I'll find out about it. Anyway. Okay,
I just, same as you, I kind of tried getting everyone to work together. It just didn't work.
Not happening.
Yeah, it didn't happen. And so, I tried.
Yeah.
I've been fairly supportive of Bill and, still as introduced and, you gotta, where I come from, the Northeast Kingdom, we don't have any doctors. So we do have optometrists, and I've spoken to them, they reached out to me, and they think they can perform all these procedures, and if they don't believe they can do a procedure, don't do it. Then they would recommend them to go somewhere else, so that's all the guidance that I can give. I'm aware of it.
Is there any requirement that optometrists carry?
behavior centers, any requirements, well,
To carry insurance
oh,
malpractice?
Oh, yes.
Okay. And there's been a couple news stories lately about people doing cosmetic surgery. They are doctors. At least they're supposed to be. And people dying and no way for the next patient to find out that this doctor has had 2 people die under their care. For something that's, so I'm wondering, is there a reporting system before I go to my optometrist and let him laser my eye? Is there a way that, can I look that up in professional regulation as to
If there's been discipline,
if there's been discipline?
right,
How about compliance?
that has to be demonstrated to be.
Okay.
no, but I will also
Or
caution you that
professional
people can complain about all kinds of things.
I know, my eyelashes got
conduct.
serious.
Right.
So I would say, I thought you did an excellent job of summarizing everything that we've learned. And I apologize for anybody who sent you the type of email that you got, because that's inappropriate. But
Maybe we'll take it up tomorrow. Maybe we won't, based on those, we will.
I've listened to all the testimony, and there's obviously 2 sides that don't want to get together on this, but you know, what I heard, and especially when you listen to, the dean of the college, shows that this is well within, the realm of practice and the education that, these individuals are receiving. And as I indicated when we talked with OPR, it's for my own license, and as John just said, if they aren't qualified to do the work and they're a professional, they will not do the procedure and will refer those individuals to somebody who is qualified to do it. So I don't have an issue with the bill.
My issue with the bill are the number of procedures that are here going whole hog out when we don't have a lot of pathology in the state. It's a huge issue for me. And knowing that we're expanding it, I understood that people are well trained. But when you are well trained, you also need to have repetitive exposure to the type of procedures that you're doing. So just opening these all up, I guess, I do have concerns about that. And I share that. I have shared that with others consistently. Oh, and thinking there may be a way to limit some of the surgeries that are here or the surgery overall, and include some of the things, expansions that would allow for some use of laser. But some of them seem, as we heard from Dr. That there are some procedures that are best done frequently and within access of hospital support services. That's actually another question I had, and maybe Dean, you can answer this, but that once one of these procedures is performed, if there is a complication, how would an optometrist handle that complication? Is there 24/7 coverage? Will there be a relationship with a hospital or another practitioner for the patient? So we're not sending the patient to the ED. I mean,
Yeah, I don't think the ED probably would be well equipped to handle. I mean, we deal with post-surgical complications already. That is within the scope right now. Most procedures, as you know, have some kind of global period, right? So depending on the procedure that we're talking about in the bill, we're responsible for the aftercare, if you will, for the time frame. If you had one of the misadventures that's a big deal. I mean, you're really going to UVM or Dartmouth, and that's independent of whether you're an optometrist or just a private practice ophthalmologist. And if you need hospital services, you're going to the specialist at the hospital.
so this is a good point. It came to me when I was looking through stuff last night, and I know that in the past, when we've had the ophthalmologists coming in here looking to have their, the ophthalmologist in my district having their clinic approved, and it was all about the CON process and how they're going to fit up and get ready to go. And then what kind of coverage will they have at the hospital? There was a big dialogue between the hospital and the practitioners. So my question is pretty basic. There has to be some relationship going on. And I know it might be one surgical procedure in 10 years that is a problem, but having a relationship with a local hospital, with UVM, Dartmouth, could be Albany, depending on where the person is. Should they have something stated about that?
It's your pleasure, of course. I will point out that in this moment, for this committee, it sure seems like optometry and ophthalmology don't get along. But I have a dozen personal cell phones of ophthalmologists in my phone, and I call them and I say, hey, I need this, or just this patient might be a little tricky, or I'm worried about this. So, I mean, it's a small state and we do have working relationships. You know, like I'm the only eye doctor on staff at Gifford. So if the Gifford ER has a problem, they call me. You know, for a long time, and Ascutney has added some providers, but for a long time, we took all of Ascutney's ER stuff in White River too. So, my residency was at the VA hospital. When I was there were no ophthalmologists there. Anything that walked into the VA hospital, and those are often very complicated patients, you know, that was optometry dealt with it. And if we couldn't, usually we had to go to Boston unless it was truly emergent. And then you were sending them over to Dartmouth. But I mean, the relationships there exist. I wouldn't foresee that being a huge problem without writing in it. If you wanted to make sure that there was some kind of working relationship, I would only ask that a working relationship, other states that have instituted optometric scope expansion have found difficulty finding sign off when it is left to ophthalmology to sign off. Right. But it's another way of sort of holding things back.
Understood, yeah. Oh. Okay, well, it's just something to think about. Might want to put something in there that. Any other questions, comments?
I have my hand up, Senator.
Oh, a voice from the wilderness. Thank you for being here, Senator. Go right ahead, please.
Yes. Oh, thank you so much. I just had a couple of thoughts as I'm listening in on you all. One is I'm thinking about what Dr. Peter Provost said on Monday, which is that a lot of times in these medical discussions, we end up in these two camps, you know, in our corners. And it seems like this is kind of an example of that, and it's really unfortunate. And so I just want to share that I'm really disappointed that that's the way that it's sort of come down. And his point was really stressing that we have to work together, right, for what's best for our state and for our constituents and for our, you know, citizens who are and Vermonters who need care. And then another thing that I keep thinking about is, you know, do we trust OPR? Because at the very heart of this is an OPR report that they have put their name on, that they have worked diligently on, that they have backed. And if we trust our own operation of professional regulation, it seems as though we need to listen to what they're saying. And so I don't want to dismiss their report and their work. And I am in favor of moving this bill forward. Thank you.
Thank you, Senator. And as I said before, my concerns rest with the extent to which we're expanding scope. And I'm not sure that we all understand what it means to require surgery of the retina, excisional surgery of extraocular muscles, cosmetic surgery for the eyelids, but that you were bringing up. There are others there. There's also surgery of the eyelid when it's impedes with eyesight, removal of lesions along the eyelid margin, and then the one that we don't do very well. Somebody can help me with this. It is, where is it? It begins with C. What one that begins with C? What that is?
Turn about choice.
Anyway. I want everyone here.
I think one or two of those read might be from the prohibition list, not from the allowed.
Oh, it is from the prohibition, not sure.
Just,
Yeah.
we're not doing any eye muscle surgery. We're not doing any retinal surgery. We're not like.
It's from the prohibition. Thank you. Right. That's why I couldn't find the one I wanted.
That language was added as part of early discussions to make sure that ophthalmology didn't feel like we were encroaching. Good fences make good neighbors.
Go ahead.
I've gone both ways on this. And I think at the end, I share your concern about the lack of patience. You don't want the doctor that does one knee surgery or one kidney transplant a year doing your knee surgery because they're learning. But I added that to the presentation on education. And I think we had two people from the optometrist. And I never saw any presentation of anybody working on an actual patient. It was models. And B, they just didn't have the gravitas that I got from the medical profession. It did not inspire confidence in me that this was a serious procedure that was trained for, under strict supervision with an ophthalmologist present on a live patient. Because there's a difference between a model. Models don't bleed, and human being. And I'm not comfortable at this point with, I'd be much more comfortable with a stepped procedure where we did two of these, probably the least invasive, taking things off your eyelid maybe, and then move forward. But the transients and maybe that's reason, but I'm not there yet.
So I'm in the place where you are, and that is, there's just too much here, just like it should be all of us, so. Understood, good. Thank you for sharing where you are with this right now, this is really important. We got it, and thank you all for being in the room with us while we're doing this. Not over. What I'm gonna say right now is we've got two other bills that we can look at, maybe three, maybe four, still working. So we're gonna set this one aside. We're gonna come back to it tomorrow. But honestly, if there's a way, I think there might be a little more willingness to move forward on the bill with a couple of things. One is that having the link with the hospital or 24/7 care, in needs. And then also, how do we limit the procedures that are here? Some of them are pretty striking that we saw, and Senator Cummings' comment can't be left.
No one should say nasty.
So,
Do the wrong thing.
yeah,
Can I just say one last thing?
not right now. What was it? I can't resist. And I'll go ahead.
In other states, legislation is
Go ahead.
often drafted as taught. And we could have done as taught, and that would have given you way many more questions. So we tried to be super transparent, and so did OPR.
I appreciate that. Thank you. And I know that that OPR did work very hard. We get it. We know. Okay, so thank you all. We're gonna move along to a new draft. Wait, so before we move to the new draft of 189, Jen has for us, we are going to go to very briefly to 154, just quick testimony on that, and then 142 and 189 to at your pleasure.
You're wanting to, you didn't take that money for it.
You want to go another, I'll go get them.
Very briefly, I
Yeah.
need so brief.
I'll let them know.
Thank you.
Thank you, everybody. I am deeply sorry about this. I will speak to that.
Yeah. That don't cause setback. I didn't have. It's not.
Well, you skate.
Not okay. I'm trying to escape.
It's unbelievable.
And guess what? I'm ready to stick it up there and leave it alone. You know, I'm not a happy person right now. Mars is in my brain. Sorry.
I got a couple of other people. I can play it up. I understand it.
I told one group once that I was a sponsor of a bill. That if they didn't back off, I was going to go against it. Okay, so thank you for being here. For the record, your name is,
My name is John Falcon.
good to see you
I
again.
live in Hartford. Yeah, thank you so much. I know you guys are extremely busy. I really appreciate you.
Right, so if you could just sort of summarize.
Yep.
We'd love it, and we'll put it up on our webpage.
Perfect. So what I really want to do is I want to talk a little bit about my experience. So my wife, Judy Simonbaum, was a really active, engaged in the community person, loved colors, loved people, was really a really wonderful person.
She was wonderful, and she was in this room.
She was. Yeah, she might have been wearing
And
this. I'm
purple.
not sure. Yeah, right, exactly. But her life ended 2.5 years ago from dementia, probably Alzheimer's. She got a diagnosis about early in the year 2020. And it was, so she lost her ability to cook, quilt, do all the things that she loved to do. Back in 2020, if you were diagnosed with Alzheimer's, you were pretty much given given some support, but get your life in order. You know, you don't know how it's going to progress. We don't know how fast it's going to happen, but this is nothing that you stop. We can't even slow it down. So there's some support, that you can get from aging resource centers or that sort of thing. There's some training you can take to learn how to become a caregiver, and I do all that. But she, her life ended sort of a mixed message, ended rather suddenly. So she didn't reach the point where she didn't know anybody anymore. She actually was brushing her teeth one morning and she had a seizure, fell backwards and banged herself on the vertebrae. And it was a 72-year-old woman, you can operation, start repairing vertebrae when somebody has dementia. So it was kind of a downward spiral, another 2.5 months after that before she basically died. The reason this bill is so important, things have changed so much in the last 3 years. I just want you to know that. In 23 and 24, the FDA approved 2 drugs that will effectively slow down the decline due to Alzheimer's. It's really significant. And I've met some people that have been perfectly competent, been spoken in front of tables and committees that have described their experiences, and they're doing great. Less than a year ago, the FDA approved a blood test that detects Alzheimer's. So it's not a direct thing. It's a balance between 2 different proteins, but it does exist. And at this point in time, Alzheimer's can be predicted pretty early. They haven't gone through the process yet to see whether they can predict it before even symptoms begin to show, but we're sort of hopeful that they will. So given these 2 pieces, if that had been available when Judy was beginning to get concerned about how she was able to think and reason, and knowing that her father had died with dementia of some sort, we certainly would have gone in the direction of trying to get a biomarker testing to see whether something was developing. And if it had been early enough, it would have been early, and these other treatments would have been available. So it tremendously improved her life, would have definitely elongated her life a lot. And the other point I would make is that but biomarkers testing is relatively inexpensive. I mean, I can't tell you what the cost is now, but compared with getting PET scans, brain scans, and having those analyzed, it's less and probably as good or better. So that's why I think that health insurance should be covering biomarkers. I appreciate your time. Thank you very much. I hope you can move this forward.
Thank you. Well, I think what we'll do, we'll try to get it down to finance where they can deal with some of the financial money issues. Because we're not a bottomless pit when it comes to funding here, but at least we can get something started and the chair will do what she does.
We will be your problem.
Sounds good. Yeah. Keep it in mind.
Thank you, John.
Oh, I get that. I get that. I was legislative breakfast from Monday. It was very clear. Very challenging. Thank you.
Thank you very much.
Appreciate it.
No, we appreciate your time and being here and being patient with our schedule today. Interesting. So, wow, as soon as Jen comes back in, we'll go right to 189. She has a new, do you have it posted up? The new draft of 189?
Yeah.
Okay, why don't we post that up? Oh.
While you're waiting for.
Well, wait.
I'll get back to quick.
Oh, Jen.
I will be very, very brief.
Okay.
Okay. So Jenny Morgan with the Alzheimer's Association.
Thank you.
Thank you so much for the opportunity to address you all again. I know I spoke to you all a couple weeks ago, so not to repeat myself too much. But we certainly think that biomarker testing increasing access not only benefits families, it benefits people living with the disease, but also has a significant financial benefit to the state. That's $63,000 in some of the cost savings that we see for individuals living with this disease. So $13,000 in personal savings, $20,000 in Medicaid savings, from $30,000 in Medicare savings. Also, just to really focus in on the cost of the disease is incredibly expensive. It's $158 million estimated Medicaid cost that the state pays alone caring for people with Alzheimer's. And as John spoke so eloquently to, you know, when we give people access to a test earlier and a diagnosis earlier, that can lead to the opportunity for them to access FDA approved treatments, delay their, you know, possibility of them entering long-term care. And also just very briefly, the science is moving so incredibly quickly. And unfortunately, you know, insurance is just not keeping up with that. So we want to make sure that everyone in the state of Vermont has equitable access to these resources to not only benefit them and their ability to figure out how they want to move forward in their life after getting a horrible, you know, diagnosis of this disease and dealing with all of that, but also to ensure that they can maximize the best treatments that not only help them, but also will benefit the state as a whole. So very, very quick, and I'm certainly always happy to answer.
No,
any
this is
questions.
good. I think your testimony will probably be most effective
Of course.
in finance.
Of course. We will look forward to it, hopefully, Senator. Chatting with you. Yeah.
It depends on our time.
We've lost 2,000 people off of just because of the cost this year. And if we add anything that isn't on the federal list, the state has to foot that entire cost. So
Sure.
that will be the hard part. Yeah, but I think it's good. I've
I'll wait till.
worked in an adult day,
Yeah.
and the only way to truly know it was Alzheimer's was an autopsy of it.
Yeah. Yeah.
A
And
living person, you'd go in, see if there were all the
right.
calcifications. We had one lady that was diagnosed with Alzheimer's, and after she got out and got active, and
Yeah.
she was just depressed and lonely.
Yeah.
So
Well, we're gonna go with the ability
it's really
to
nice,
test.
especially if there's something you can do other
Treatments
than
now.
held off.
Yes, absolutely. And again, just want to reiterate that the science is moving incredibly quickly. We're so excited to see what's happening.
That is good.
And we want to make sure Vermonters have access to that.
So we're gonna end here, but I will say this, I just will say one thing. When you have a test that becomes predictive of Alzheimer's and it's validated that the test links with the postmortem evaluation of the brain, then you know it works. So that's what we're talking about here. We're not talking about the woman who went to,
No, but if
Okay.
you had been able to do a
Yeah.
simple test,
Yeah.
you would have known what we were dealing with a lot sooner. Yes.
So we're gonna move on to one
Thank you so much.
eighty-nine.
See you tomorrow.
Jen Harvey, who will help us understand what.
Thank you.
Thank you, Johnson.
I think that's all first. That's sorry, I don't know.
A present for Senator Bulick on her desk. Gets all the papers.
How much is?
Good.
I've rounded out my cow collection.
Oh, okay. Oh, your cow collection. My cow collection's at home.
All right, hello again, Jen Carvey, legislative council. This is good. I got a little extra charge on my battery, so it stopped being in low battery mode.
Wait, do you need a plug?
No, we're gonna leave here for a little bit. I mean, if it works.
Of course it does.
Well,
might
we're
not
not,
work.
I'm not saying.
It works on mine. I know.
It looks right.
My new iPad was a regular one, not a specialized iPad. But remember, that's mine.
Yes.
But it does say slow charger, speed up charging, use a higher watt charger.
Yes, when I plugged my phone in and my phone got hot, I had to unplug it.
All right, so I'm back with a new draft of S-189 that just incorporates all of the previous changes, and so it's 3.1, Calista has it posted.
Got it. Wonderful.
So should I forget to take the highlighting out? Well,
Sorry.
yes, that. Oh, this is not the right thing. Either I didn't send her the right thing or it's misposted, so ignore that one.
Okay.
And I will put up the version that is on my screen. Hopefully.
So this could be 4.1.
No, it should, 3.2.
I was.
3.1 is what we looked at this morning.
Right.
All right. So I'm not sure if it's on there.
It's all right. You're gonna put
All
it
right,
up.
but I'm gonna put it up. It's, the changes are minimal. It's just we talked about. For technological issues here. All right. 3.2. So yeah, we incorporated intentionally. Whatever else. Bigger. So the change that I made was here, and I didn't try to show strikeout, whatever, just flagging it for review. So board may adjust on the proposed budget as necessary to reflect the elimination or reduction, may include directing savings, a return, and then I said to Vermonters to address affordability concerns or to payers to be reflected in health insurance premiums or are reinvested in primary care prevention and other community services. So flipped payers and Vermonters, we kept the affordability concerns specifically around Vermonters. The payer was also kind of in that area, but we said more specifically reflected in premiums. And that's it. That's the only change.
I'm not seeing the yellow one for some reason.
I don't think.
You don't have it.
Oh, I know.
I'm not sure it was
No,
posted.
you don't
Got
have
it. That's okay.
I think I will make sure that I sent her the right one. Sent her 3.2.
Or yellow, ready this morning.
Yes, these were being.
Yeah, I can't post it until she's back, but they did. I believe I did send it to her. So
Where did she go?
for me, we need to get them. She wants to make copies. I'm saying for you, but
I don't know.
Can we grab a piece of paper? Here, who's the clerk in here? Here's the clerk. It's,
yay.
Oh, here she is. Here she is.
no, we need a thing.
Because I got
I'm gonna ask for
and three
motion on S-189 draft 3.1 as presented.
3.2.
Oh,
3.2
3.2. That's why I couldn't. That's
was not on there. No.
yeah. Okay.
Yeah, what's the, it'll be today's date, Jim?
Today's date, yep.
On the
And it's,
draft.
yeah, here, I can go back up on this.
This is 197.
This is 189.
89.
Yes, and there should be 3.2.
Like, people do- yeah.
Oh,
I keep trying to email instead of sharing my screen.
I will
Go for it.
Oh, and Senator Buick has her hand up.
okay.
Senator Gulick, what?
Sign has her hand up.
Thank
Oh,
you.
Senator Gulick has her hand up. Go ahead.
I'm sorry. I think my brain cells are not firing quite as quickly as they normally would, but is there any way someone can summarize in a few words the changes that we made from the original bill?
From the original S-189,
Yes.
which you're talking about, sure, I can do that. So the original S-189 was a review and approval process. So it would have required it would have prohibited a hospital from reducing or eliminating any service without approval from the Agency of Human Services. And so it still had the public engagement process that's in the bill, but then it would direct the agency or give the agency authority to approve the proposal or to disapprove a proposal. And this instead has, and then still have the Green Mountain Fair Board look at the budgetary impact if it goes forward. This instead has the public notice and engagement process, but has the Agency of Human Services review and provide a non-binding recommendation instead of having a strict approval or disapproval process.
And then when the plan is in place, it will go to AHS to continue to do this.
Yes, it is now plan agnostic as far as when the plan starts, but it does have them reviewing for consistency with the plan once the plan is established.
Right.
I will.
Senator Gulick, does that answer your question?
Yes. Thank you. I appreciate that.
Okay, and remember what we heard from AHS was they aren't regulators in this arena. And so they felt that, and that we're also in a stage of development around the statewide plan. So we tried to put in the transitional process for this.
Yeah, and that's great. I just wonder, where does the buck stop, actually? Like,
You're good. It's a good question. And it's probably something we're going to have to deal with once that plan is in place. You muted yourself. I don't know if you're still talking.
I know, I'm trying to, I guess I'm a little disappointed that we don't have a clear final arbiter in what happens, that's a bummer.
Well, and the debate will go on between the board and AHS. I think we've gotten to a place that's doable. And in the future, it might be more, it might be adjusted more toward budgetary decisions, but right now it's more toward planning decisions. So we're all in the same place of limbo.
Okay, thank you.
Yeah, thank you. How did you do that? You were muted. She talked and she was muted.
I can unmute myself.
I know, but when you said that before, it was red. That's curious.
I don't know.
Right. All right, go
I'm
ahead.
going to move
Yes.
3 times a year.
that we approve as 189 version 3.2. And I don't have, it would be 3/12/26?
Yep.
Yeah.
And I don't have,
Time is 11:01.
and 11:01,
To the full Senate as amended.
yes.
Are we good with that? All right, discussion on 189. Any further questions? Senator Gulick, you raised a good question. Good discussion. Is there anything further? I'm looking to you first. Oh, I can't see her anymore.
No, I guess I would like to hear from my colleagues in the room how they're feeling about it.
Okay, we'll do that right now. So any discussion?
I mean, to me, the most important part was the public process. And that this bill gets us that.
And that was something that was put into the bill. It wasn't in the underlying bill. We added that public process.
I'm with you, I'm with John on that, I agree that public process was important and critical one. I'm good.
Okay.
Yeah, all of this is a real balancing act, and we're asking the hospitals to do a lot. At the same time, we're asking them to cut their costs. At the same time, the majority of them are in danger of going under financially. And so if we tell them to cut their costs, then didn't tell them they can't cut anything unless the public entirely approves. We're asking to do the impossible. And there's gonna have to be compromise. Or the whole system will crash.
Well, I think there's another issue in this, and I think it's the one that Senator Gulick has really identified, and that is the responsibility for decision-making between the board and the Agency of Human Services. And that's going to be an ongoing debate, and we are going to have to face that in here and make, absolutely go through who's doing what, when, and how. And right now, there's a lot going on out in the real world with hospitals and community services, which is, it's another whole thing, but we're going to have to face that. And I think Senator Gulick, you did raise that question, and it's really on target. So thank you for doing that.
Thank you, Chair Lyons. Can I ask a quick question? Because Senator Cummings keeps aptly mentioning that some of our hospitals are on the brink of going under. Can someone expound on that a little bit?
Well, we don't, going under, I think, is they're in the red. So a hospital like Springfield, and then last year Gifford was in the same place. And
They're
they're
not in the red. I think you
there's a
got some
lot of
testimony from Owen
This-
Foster and the board earlier this
Yeah.
year showing the
got
financial
named,
situation.
just a whole bunch. North
They're in
Country,
the red.
yeah, they were all in the red, and that's why they're all working really hard right now on transformation, so they can pull themselves out of the red and into the black.
Even UVM.
We have a
Right.
chart,
There's a
yeah,
chart.
we
That's
have,
what I was gonna
it came from the Green Mountain Care Board when Owen Foster testified, and I have it actually right here with me, and my,
Pull it up and see if I can.
I have one right here.
And even UVMC just made it over it's the number of
No,
days cash on hand.
Yeah.
They were at the lowest level
Oh,
of where.
Because it was,
So I could tell you Central Vermont, Copley, Gifford, Grace Cottage, these are all 23, 24, the final, most recent data. North Country, Northwestern,
Here, I can.
Southwestern, East Springfield, they're all.
Here's if this is helpful, here's some testimony from Owen Foster from the beginning of this
Yeah.
session. This is the FY 26 budget, and you can see the days. Cash on hand, operating income, operating margin.
Right. So there's a bunch.
Yeah.
Okay, any other discussions, questions? I'm good with moving ahead with the bill for all the stuff that we've done, and we also have concerns. I get that. We're always gonna have concerns.
ready?
Yeah.
Senator Benson,
Yes.
Senator Cummings,
Yes.
Senator Gulick,
Yes.
Senator Morrow. Yes. Senator Lyons.
Yes.
5-0-0.
Good discussion. Thank you for that.
I'm not gonna put the time on.
So now we're gonna figure out who's gonna report this little darling. And I'm glad to do it if nobody else wants to do it. No, oh,
you're happy with.
I'm anticipating having.
I know you will.
I may not get them out, but if I do, I will have.
Yes, I'm looking at two more bills that I definitely want to do, and I know others are gonna want to do some of these things. I'm happy to do it. See it as the lesser of several evils.
This one should be piece of cake.
So we have S-142. And what I'm gonna suggest is that we give ourselves 10 minutes for the day. Unless, what 142 is the,
International medical graduates.
yeah, and I've had a conversation with Department of Health. They desperately want to figure something out and reach out and look at other states, and figure out what they can do. So they would like to have the bill, be put out further. So I'm trying to think if you will allow for some dialogue with Jen. I was thinking about, having the Department of Health do that, reach out, make and bring back suggestions that would improve the process that's in the bill by a date certain, so that there is a deadline. And if they don't come back and they don't fix something in there, or we don't fix something in there, it goes into effect. And that's a hard stop. But on the other hand, it goes to the House. So I'm trying to figure out what we can do in the minimal time that we have, and anyone who has a better suggestion, I am open to that. And so we'll get a suggestion from the Board of Medical Practice, Department of Health, and they will help us with this, and then we'll look at it tomorrow. The best we can do with that.
Yeah, I think it's worth moving forward, understanding that it will get fine tuned.
Yeah,
Totally.
I agree that the issue was
Yeah.
who has the capability to really vet this.
Yeah.
It wasn't the medical association. They were looking at a contracting out was.
Well, that
They
was,
they suggested that as something they might explore.
Right.
Yeah.
The workers'
All
comp.
of which means money.
There you go. There you go.
It just be fine.
So Madam Chair, can you clarify, so we're not doing any kind of, you don't need anything new from me on this for tomorrow? You're looking for something from the board on this, or are you looking for me to?
Well, I'm looking for language that will come from the board, and maybe you and I can have a conversation, and then we can bring something, a suggestion onto the table. I don't want to be writing it outside of committee, but I think at this point, let's see.
I mean, if you want me to sort of, have a general
Yes,
concept of board, go look at ways to do this and come back and report in
Yes.
January.
yes,
I can do something like that.
that would be helpful.
Do you know what date certain you would like, further date out, you would like for the effective date of the?
I'm looking right now at what is the effective date in there.
I think it was, well, it was introduced last year, so it needs a new effective date anyway. It was gonna be a year out, that was July 1st. So if we did nothing else, I would be updating it to July 1st of 2027.
We could make it January 28th. Or we could leave it 27.
I mean, right now it's 26, so it has to get amended anyway.
Yep.
But that was because it was introduced last year. So
If they come back with recommendations, would have that time to change it, right?
Yes, that,
yes, and you part of the reason for pushing it out was to give them time to do rulemaking. So you do
Yes.
need to factor rulemaking in.
yeah.
So if they come back in January with something, I think January of 2028 would be the earliest you could have it, but even that may not be enough to.
So if they bring it back in 27, then
Yes.
this would not. We would have time to work on it.
You would, but if you changed what you were telling them to do, they might not have time to do rulemaking by January 28th.
Understood. Got it.
So maybe you want to make it July of 28.
Right.
That,
Oh, you're talking just about effective date.
Effective date.
Just for those sections. Yeah, got it. Yeah.
right, I mean, the go
Yes.
forth and look at things would be effective on
Right,
passage.
Right.
Okay,
And then the rulemaking and then other stuff.
yes, so we'll do July 1,
Hey, whoops,
We're not voting anything else right now.
we've got 2 minutes and
So Senator Gulick, are you listening?
we've got meetings.
Yep.
Okay, so are we okay with trying to do something like this so we can get this bill moving?
Yes. Yep. As long as we can vote on it tomorrow, that's great. Thank you.
All right, good. And then the other one we want to vote on tomorrow, and I know it'll be a heavy lift, but I might talk with Jen about the cost of the biomarkers. I don't know, we can cover everything, but to the extent practicable, or that would allow for cost savings. I don't know how we say it.
Yeah, I mean, I don't think you can. If you put in a coverage requirement, the state will have to pick up whatever the defray, whatever the increased premium for the qualified health plans is. I don't have any sense for what that will
Ditto.
be.
Yeah.
To
To cover costs for initial and one test a year. I mean, I have no idea what to say that.
yeah, I don't either. I mean, it seems like maybe you want the information about what the premium would be, increased premium would be before you decide what you can fund.
We'll let the finance committee do it. I just ran over a wall. So I think it goes to the finance committee.
Right, so I mean, right, you could vote it out of here as it is and then punt it down to them.
I like,
But the cost aspect of it, I feel like the cost aspect is gonna land in appropriations, not finance. It would be in finance for the insurance aspect, so you might have to ask for, be referred, in which case I don't think it may not be crossover.
Wait, well,
It wouldn't go to finance by operation of Rule
31.
31, because it doesn't affect the revenue of the state, it affects the appropriations.
but it came from finance.
It
So,
came from finance because it went to finance because finance has jurisdiction over insurance.
right,
It didn't go to finance because it affects the revenues. of the state.
understood. So it still has insurance in it. Maybe I should talk to.
I would talk to Bloomberg.
We'll vote on this tomorrow.
Okay, because the way I understood it, it's gonna be passed out of the committee of jurisdiction.
It has to be passed generally out of policy committees, and the money committees get an extra week because of the money aspect,
Right.
not because.
Right, finance and
on
a
an
public.
insurance, but not because it goes to finance on an insurance issue, it's because of. So that's what I wanted to clarify.
Yeah.
I mean, the other thing we could do is we to lift it and send it, be relieved of it in this committee and send it to another.
Yes, I think you'll just need to get some clarity from Secretary.
I'm going to
Blumer
get
about
clarity.
Whether tomorrow's deadline applies
Understood.
to the finances consideration.
All right, we're good. So that's a wrap.